heart failure. Basically, this will be a proper playlist of all the videos which will be pertaining to heart failure, the types of heart failure, their management, and the interventional procedures which are done in case of heart failure, like cardiac resynchronization therapy, etc. In this video, we will be, focusing our approach to heart failure only the basics of heart failure, like definition, stages, classification, signs and symptoms, investigations, right? So, heart failure definition. It is a complex clinical syndrome, right, that results from any structural or functional impairment of ventricular filling, that is diastole, or ejection of blood, that is systole. This is given by the ACC, American College of Cardiology, or American Heart Association, ACC-AHA definition. Here, basically, there are three, components of this definition. The first is that any structural or functional impairment of ventricular filling, that is diastole, or ejection of blood, or systole. Third is it is a complex clinical syndrome. It is not one thing. It is a syndrome. There are various signs and symptoms which are there in this clinical entity. So it is a complex clinical syndrome resulting from structural or functional impairment of ventricular filling, that is diastole, or ejection of blood, that is systole. Second is the staging of heart failure. Staging means what is the clinical progression, or what is the stage of the heart failure, that how much it is compensated, how much it is not compensated. Stage A is basically it is there is no sign or symptom of heart failure, but the patients are at risk of heart failure. They can develop heart failure in coming future. At risk of heart failure, for example, patient is hypertensive, diabetic, obese, or he is having metabolic syndrome. These are all patients which have these metabolic derangements. They can develop heart failure in future. That is why they are at risk of heart failure, and they are classified as stage A. Stage B is structural disease is present, but there is no sign or symptom. Right? Let me write for you. Structural disease is present, no sign or symptom. Structural disease present, no sign, no symptom. Stage C is somewhat different. Here there can be structural heart disease, but the main thing is these patients are basically symptomatic. These are symptomatic, that is why they are stage C. Means all the patients coming to you in the OPD are basically stage C heart failure patients. Stage D is basically advanced heart failure, in which you have to do some urgent therapeutic intervention in order to save the life of the patient. For example, a patient coming with pulmonary edema in the emergency, and you give 20 milligrams of Lasix for pulmonary venodilation. That is some intervention that you have to do as fast as possible in order to save the life of the patient, and it is basically stage D, or advanced heart failure. Uh, and stage D is at the same time it is recurring. You treat the patient will again land up in heart failure. You treat the patient, again land up in the heart failure, and that too at very rapid intervals. And it requires some specialized treatment. Specialized treatment can be some resynchronization therapy, or they may require heart transplanting itself. That is advanced heart failure. Means the simple medications that you give to a stage C heart failure patient, they will not work in advanced heart. I mean, despite the medications, the patient is still symptomatic. That is advanced heart failure. Now we have to study the NYHA classification of heart failure. NYHA means New York Heart Association functional classification of heart failure. In this classification, we basically see the functional reserve or the functional ability of a patient with heart disease. The first criteria is the patient should have a heart disease. You cannot apply NYHA to a COPD patient. The patient has to be a heart disease patient, right? Class 1 is that there is no limitation of ordinary physical activity, no sign or symptom on ordinary physical activity. For example, the patient daily goes for a morning walk, he will not, experience any sign or symptom. Or if a patient is, a laborer and he is having a heart disease, but the patient is doing daily labor, despite being, a heart disease patient, the patient is not having any symptom, but he is able to do his ordinary activity, whether he is a laborer, whether he is doing just morning walk, or whether he is just moving from one place to another. Ordinary physical activity is different for everybody. Ordinary physical activity for me is basically sitting on a chair for the whole day long. Ordinary physical activity for a laborer is basically lifting heavy weight, or whatever the work is there for him for the whole day long. So different individuals have different ordinary physical activity, and we have to delineate that what the patient is basically able to do, and whether the signs and symptoms are there at this particular activity or no. Class 1 means class 1 means no limitation. Class 2 means some limitation of ordinary physical activity. Class 3 means limitation of less than ordinary physical activity. And class 4 means no physical activity, the patient is symptomatic at rest. Why NYHA is important even at this point of time in the course of the advancement of the heart failure? Because NYHA functional classification is a very strong predictor of mortality in the heart disease even today. Symptoms included in NYHA, we are discussing that no limitation, limitation. What limitation? Limitation means development of signs and symptoms. What signs and symptoms? There are basically four signs and symptoms. Four symptoms. First is the angina, then dyspnea, then fatigue, then palpitations. Right. So these are the four signs or symptoms that are included in order to do NYHA functional classification. Now comes the classification on the basis of echo. When we do 2D echocardiography, we basically look at the ejection fraction of the left ventricle, that how much amount of blood is coming and how much is being pushed forwards. First is the reduced ejection fraction. Reduced ejection fraction. Second is the mid range, and third is the preserved. Preserved does not mean normal. Normal is basically 57 to 61%. But here, if ejection fraction is more than 50, it may be 51 also, maybe 52 also, maybe 53 also. So these individuals we will classify as heart failure with preserved ejection fraction. Even the patients with ejection fraction of 65% can have HFpEF. That is the short form. There are basically other criteria to diagnose HFpEF, but basically I want to emphasize on the fact that ejection fraction more than 50% with signs and symptoms of heart failure is basically HFpEF. That is 2D echo classification. Reduced means less than 40% ejection fraction. Mid-range means 40 to 50% ejection fraction. And preserved means more than 50%. So these are three kinds of heart failure which can be found, and we can classify them according to the echo report. How do you diagnose heart failure? There are basically two criteria. One is Framingham criteria, second is the Enhance criteria. Framingham criteria is basically derived from Framingham study that was started in 1948 and it is still continuing. 70 years plus have passed, and the study, the most of our understanding of heart failure has come from this study only. Framingham criteria. There are basically two major criteria which are required, or one major, two minor criteria are required for heart failure. Right? Let me see if I'm right. Yes, one major, two minor. So this is the Framingham criteria. Second is the enhanced criteria. It is also used basically in clinical trials for including the patients. Let us not go into details of enhanced criteria. Signs and symptoms of heart failure. See, this is very important. Patients come to you with what signs and symptoms so that you proceed towards uh, workup and diagnosis of heart failure. First is dyspnea. Second is the creps, or V's can also be there, or what we call creps as rails. Tachycardia is mostly found. Pulses alternance. Pulses alternance is basically a disorder of pulse volume, and it is because of impaired relaxation of myocardium. Recovery is not complete, so that it takes one complete cycle for the myocardium to recover, such that in one cycle there will be normal complex. In second cycle there will be low volume complex, and it is the time taken by the myocardium to recover. And in next there will be uh, you know normal sized complex. So one normal complex, one small complex, and the next complex is again normal. That is, recovery has occurred, and this is the time taken by the myocardium to recover itself. So this is basically pulse volume. In this particular electromechanical cycle, the pulse volume will be low. It will be normal in this cycle, normal in this cycle. Right. Then elevated JVP, that is what we see most of the times on bedside. It is a very specific sign. Hepatojugular reflex, that is you press the right upper right hypochondrium, and you see an elevation in JVP. It must be sustained more than 10 to 15 seconds so that we can call it as hepatojugular reflex positive. So HGR is also very specific sign for heart failure. Then S3. S3 means the left ventricle myocardium is a little stiff, so that when the fastly coming blood from the left atrium, it decelerates on touching the wall of the left ventricle. A sound is produced, third heart sound, right? And third heart sound is basically a significance that left ventricle is not that compliant. It is stiff. There is diastolic dysfunction, and it is present in heart failure. Although it is present in normal individuals below the age of 40 in pregnancy also, but in heart failure you can find S3, right? S4 is basically the work of left atrium. When left ventricle fails and left atrium has to work, right? Contraction of left atrium will push blood into the non-compliant left ventricle, and it will produce S4. S4 is, remember, always pathological, and it is found in heart failure. Then is the pedal edema. Of course, right heart failure will cause hepatic congestion and pedal edema, and then pleural effusion also. Though there is, changes in Valsalva also, but it is a very different and very, you know, a very vast topic in itself, and it is not in the scope of discussion in this video. So we are not discussing Valsalva, but you can remember that Valsalva, the phases of Valsalva, they are a bit different in heart failure uh, from what they are in a normal individual. Two very important questions. Most sensitive sign of heart failure is orthopnea, and most specific sign of heart failure is hepatomegaly. Right? Orthopnea and hepatomegaly. Sensitive and specific. Sensitive is orthopnea, specific is hepatomegaly. And it is more than JVP, it is more than S3. Right? S3 is also specific, JVP is also specific, but hepatomegaly is the most specific. Investigations. In chest X-ray, you will find curly V lines, which is basically fluid in the interlobular septa. This is the X-ray, and these are the curly V lines directed towards the hilum. ECG. We will see low volume complexes, or you can see pulses alternates also. On echo, you will see reduced ejection fraction, raised LV-EDP, left ventricular end diastolic pressure. You can see other, wall motion abnormalities. Means all the causes of heart failure, basically, whether it is preserved or whether it is reduced ejection fraction. Comorbidities like hypertension, diabetes mellitus, uh, and their consequences on heart, they can be visible on echo. Basically, echo means ejection fraction in heart failure. That's all. Though we have to look beyond ejection fraction, but the first and foremost that we have to look is heart failure, is ejection fraction. Then we have to look end diastolic pressure also. We have to look some LA parameters, LA enlargement, LA index. So these are all the things that we see on echo. So echo is quite helpful in the screening and diagnosis of heart failure. Then other investigations routine like CBC. CBC be, will be suggestive of some cytological abnormalities like microcytic hypochromic anemia, because in 30% patients of heart failure, we see iron deficiency anemia or anemia in itself, right? Then is the hyponatremia. Why hyponatremia? In heart failure, there is activation of RAS, right? At the same time, there is activation of, there is increased ADH release, vasopressin, right? These two mechanisms will cause water reabsorption. RAS will cause sodium ion reabsorption, and it will lead to water reabsorption, while ADA will cause free water reabsorption. So, after all, water is reabsorbed more than sodium. There is dilution of hyponatremia. It is very important, very important. In almost all the patients of heart failure, you will see dilution of hyponatremia, that is volume overload. This volume overload will cause, you know, heart failure, and heart failure will cause volume overload. So basically, this is a vicious cycle. You have to break it by giving diuretics. By diuretics are basically for congestion. You have to inhibit RAS. So RAS inhibitors that are central in the treatment of heart failure. Very important. This is the reason why we will give RAS inhibitors like ACE inhibitors and ARBs and ARNIs in the treatment of heart failure. This is the rationale for that. Then comes the biomarkers, that is ANP and BNP. We do not do ANP routinely, but we do BNP routinely in our patient of heart failure. Basically, BNP has a negative predictive value very high of 95% or more. So basically, BNP and anti-pro BNP are done to rule out heart failure. Means if BNP is negative, heart failure is not there. But if BNP is there, heart failure might be there, might not be there, because BNP is not specific. Though it has high negative predictive value, but it is not very specific. Why? Because it is elevated in many other in many other conditions also, like sepsis. It is elevated in COPD. It is elevated in CA. It is elevated in diabetes also, obesity also. So, though obesity decreases BNP, but many other conditions in which there is elevated BNP.